Today is our seventh case. Previously has been case discussion has been done by the Dr. Ajay Shah, Dr. Shailesh Loda, Arvind Gupta, Anil Samaria, and Neeraj, as well as Dr. Surendra Kumar. Today we have a learned speaker with us, Dr. ABHISHEK PRAKASH. He is DNB in Endocrinology and a young dynamic endocrinologist at Manglam Super Specialty Hospital. And before we go for the scientific program,
while using
I
this,
will request Dr. K K Pareek sir, our patron, to say few words for our audience. Dr. Pareek sir, few words of blessing.
Thank you, dear. Thank you, dear. Good evening, friends. Welcome to this CME program of RSSDI Rajasthan State Chapter. Today is the 7th lecture of this online CME program on case-based discussion. It's really a pleasure to welcome all of you, and especially our chairman, RSSDI Rajasthan Chapter, our dynamic chairman, Dr. Girish Mathur, whose visionary concept of this dissemination of knowledge to our colleagues through online CME program is very popular and helping in educating and updating our colleagues and clinicians. So thank you very much for sparing your valuable time for this program. I also welcome our dynamic and energetic honorary secretary of Rajasthan State RSSDI, Dr. G D Ramchandani, whose untiring efforts are being made for the success of this program, and his efforts and hard work is being greatly appreciated by everyone. It's my pleasure to welcome our Chairman-elect, Dr. Prakash Keswani, who is the backbone behind these CME programs and who is very nicely conducting and doing hard work in programming these online CME programs. Without whose support, it would have not been possible to have these programs. I welcome today's learned faculty member, Dr. ABHISHEK PRAKASH, Dr. Anil Samaria, Dr. Sanjay Saran, and Dr. Deepak Gupta, who are panelists, and their commitment towards disseminating knowledge is really being appreciated by everyone. Today we have a very interesting case which will be discussed by Dr. ABHISHEK Prakash and will be discussed by all the panelists and all delegates. So enjoy today's CME program. Thank you so much.
Thank you, sir. Thank you for your nice words. Whenever we see you, we always have inspiration, and for last 25 or 30 years, we are seeing you, and with your inspiration only, your leadership only, we are able to do all these CMEs.
Thank you, dear.
And now I will invite Dr. Girish Mathur, sir, our dynamic leader who has done so many good things in the API National also, and he is the API president as well as the president of Rajasthan RSSDI, and with his inspiration only, these scientific programs, the obesity as well as this case-based discussion has been started. I will invite Dr. Girish Mathur, sir, to please say a few words for us.
Thank you, Prakash ji. Good evening, friends. It's my pleasure to welcome you all at this 7th session of online series of case-based discussion organized by RSSDI Rajasthan Chapter. After each session of this online series, this program is becoming more popular, and we have received very positive feedback and inputs about its content and usefulness. I extend my very sincere thanks and gratitude to our mentor, Dr. K K Pareek sir, for his constant blessings, support, and encouragement His presence is a great source of inspiration for all of us. I find myself short of words to compliment, congratulate, and thank enough our project director, Dr. Prakash Keswani. All credit goes to him. It is due to his tireless efforts. This program is being
No, sir, it is you all.
regularly without any break. I am grateful to him. I also welcome and thank our dynamic secretary, Dr. G D Ramchandani, for his constant support and help. Today, we have Dr. ABHISHEK Prakash, a young and energetic endocrinologist from Manglam, Medicity Hospital, Jaipur, to initiate the case-based discussion. To further enlighten our with their wisdom and skill, we have a distinguished panel of panelists. Anil Samaria, JLN Medical College, Dr. Sanjay Saran, Associate Professor, SMS Medical College, Jaipur, and Dr. Deepak Gupta, Consultant Endocrinologist, EHCC, Jaipur. I sincerely extend my greetings to all of you and wish the program a great success. Thank you, Prakashji.
Thank you, sir. Thanks a lot for your nice words. And without wasting much of the time, I now invite Dr. Abhishek Prakash to start your case.
Thank you, sir, for kind words. And just wait. Yes. Thank you, sir, for the kind words. First of all, I would like to thank RSSDI Rajasthan team. And I would like to especially thank all the senior sirs, Dr. Pareek sir, Dr. Girish Mathur sir, and sir, to give me an opportunity to present this case. And I would like to keep the case as basic as minimum so that it is beneficial to all of us. So is my screen visible?
Yes, visible.
Okay. So before going further into the case, I would just like to highlight the purpose of highlighting this case. This case is basically a case of uncontrolled diabetes. And as we proceed further in the case, we will see that many a times we come across cases where we are giving adequate medicines, the patient is following diet and lifestyle, all the necessary care is taken, still the diabetes is not controlled. So we have to think out of the box, and we have to think for other causes also, for secondary causes of diabetes. So with this case and with other things in mind, I would like to proceed further, and I would like to introduce my case as a case of Mrs. R, who was a 38-year-old married female and had came to endocrine OPD with primary chief complaints of having uncontrolled blood glucose since last 9 months. So basically, she had complaints of a mass coming out from her perianal region. This was a 1-year-old presenting complaints. So she was having facing this difficulty off and on for the last 1 year. All the detailed history was taken regarding this prolapse, and it was only during the pre-anesthetic screening she was diagnosed as having raised blood glucose. So initially, since it was just a preoperative clearance for the procedure, rectopexy procedure, so she was initially managed in the medicine department at the ESI hospital, and then she was referred to us. So basically, as regards the diabetes history, at the time of the diagnosis, when she was obese at diagnosis, she was having osmotic symptoms, and the initial blood glucose was 203. So she was labeled as type 2 diabetes and was advised diet and lifestyle, and started on oral anti-diabetic drugs. So initially, patient couldn't recall the name of the drugs, and there was no history suggestive of any complications of diabetes like tingling, numbness, or blurring of vision of fluorescence in eyes. So as per the patient, after being diagnosed, she told that she was having a proper diet pattern, and she used to take the medicines as per the prescribed schedule. So after starting of medicine, over the next 2 to 3 months, the blood glucose were monitored. The lab glucose were done. She did not used to do HbA1c or SMBG was not done, but she told that whenever the lab glucose readings were done, they are getting persistently elevated. So after 2 to 3 months of initial OAD treatment, she was switched to insulin regimen. So patient was very confident that I'm taking diet properly, I'm taking all the medicines. So she told even I'm following the insulin schedule. So basically we asked in detail regarding the insulin history, what about the type of insulin, about the injection technique, where the site rotation, the transport, the storage, all the aspects were asked in detail in order to find out where the problem lies. So despite digging in regarding the diet, lifestyle, insulin, everything was coming out to be proper. And there was no history suggestive of any insulin injection related side effects like lipohypertrophy, any skin bumps at all. So apart from the uncontrolled diabetes part, patient also characteristically told that she is having increased weight gain and in the form of tightening of clothes, more so in the abdominal area. And although the weight was not documented, but the weight increment was around 10 to 12 kgs over the past 1 year. When we asked her, the unhealthy eating pattern was there along with the sedentary lifestyle and decreased physical activity. But since her primary complaint that I'm gaining weight, and especially so in past 1 year, so it was very significant history which she used to highlight often again and again. And as regards the history, there was no history of snoring during sleep or any daytime sleepiness suggestive of obstructive sleep apnea. Neither there was history suggestive of any hypothyroidism like puffiness of face, cold intolerance, or constipation. So she told that she had one renal stone. Again, that was not documented. Apart from that, there was no history suggestive of chronic kidney disease or any systemic disease. Coming to the treatment history, she admitted on grilling that she used to take some oral tablets, and she told that roughly she has taken for around 4 to 6 months in the form of oral tablets, although the exact name, nature of the tablet was not known. And at the time of presentation, she was on premix insulin, sinagliptin 5 mg once a day, metformin 500 milligram twice a day, and glyphosate 60 mg twice a day. She had a family history of diabetes in her mother, which was diagnosed at the age of 55 years. And regarding menstrual and this menstrual history, the periods were regular. So with this background, she came to us with uncontrolled diabetes, with history of weight gain. The fasting blood sugar was around 260. There was slight mooning of face which was present, and centripetal obesity was there. So with this backdrop, we admitted her for workup of Cushing syndrome. And as regards the negative history regarding the clinical features, which I will explain after the case also regarding the symptoms and what we do, there was not much significant history regarding the other clinical stigmata of Cushing syndrome. So coming to examination, she had waist circumference of 86, hip circumference of 93 with a waist hip ratio of 0.92. And the BMI was 34.375. Her vitals were blood pressure 122/70. There was no hypertension, neither there was any history of prior hypertension. Pulse were 80 per minute regular, and other than that, there was no significant finding. In the head-to-toe examination, the positive findings in our case was there was slight mooning of face present. No facial plethora was there, with increased dorsocervical fat around the neck area, and there some stria were present at around the periumbilical area, but they were pale pink, and their width was also less than 0.5 centimeter. No spontaneous bruises or other features were present in this case. Systemic examination, it was there was no any abnormality detected in the systemic examination or in sensory or foot examination. So till now, just summarizing the history and the examination findings at this point of time. So she is a 38-year-old female having family history of diabetes, and diagnosed as a case of rectal prolapse during the pre-anesthetic checkup, and with a history of intake of Ayurvedic medicines, maybe steroids. And her predominant complaint presenting was uncontrolled diabetes with increased weight gain, approximately 10 to 12 kgs over the last 1 year. On examination, centripetal obesity is present, and Cushingoid facies was there, moon face was there, but there were no other discriminative features of Cushing syndrome. So presenting, if such a patient presents to us, although since type 2 diabetes is very much common, of course, the differentials that which will come to our mind will be type 2 diabetes. And that's why everyone will think further ki it is type 2 diabetes, something is there. The patient is not following the insulin schedule, or maybe the diet, and she is not actually following, and she's just saying that. But still, that's why type 2 diabetes is usually the first diagnosis. And now in this case, the history of some Ayurvedic medicine is there, so we'd also like to keep Cushing syndrome before proceeding further with the investigation. So with these two investigations in our mind, we proceeded further. So during the investigative workup, triglycerides were slightly raised with a HbA1c of 8.2%. The thyroid functions were normal, and the routine investigations, including CBC and other liver function or kidney function tests, were normal in our case. Since we had this picture of Cushing syndrome also in mind, we proceeded with a battery of investigation. Of course, the problem with Cushing syndrome is always that it is not a single test which will diagnose, and also it is not a single time where we get all the results at one go. So we have to proceed step by step, and that's how we proceeded. First, we did a serum cortisol at the 8 a.m. morning cortisol, which came out to be 13.6 microgram per deciliter. So it was against the favor of exogenous Cushing syndrome. Simultaneously, we also did a 4 p.m. serum cortisol and a midnight cortisol to see the change in the diurnal rhythm. Normally, there is a circadian rhythm in our body in which the morning cortisol and the evening and the midnight cortisol, there's a circadian rhythm. Normally there is a fall, but in this case we are saying that there is loss of the circadian rhythm, which is usually the first sign, the first investigative finding which we see in a case of Cushing syndrome. Proceeding further, we did a serum cortisol post 1 milligram ONDC, and it came out to be 6 microgram per deciliter. Normally, whenever we give 1 milligram dexamethasone at 11 p.m. and we measure the serum cortisol the next morning, it should come out to be less than 1.8 microgram per deciliter the next morning. So in this case, it came out to be 6, suggesting that there is cortisol excess, and even after giving the dexamethasone, the cortisol is not getting suppressed. So proceeding further, we did further a low dose dexamethasone suppression test. So when the two screening tests came out to be positive, and we proceeded further with a plasma ACTH, which was raised in view of excess hypercortisolemia with raised ACTH, we suspected ACTH dependent Cushing syndrome. We further proceeded for high dose dexamethasone suppression test, in which there was normally, if in a case of Cushing syndrome, if there is hypercortisolemia, in order to see the source of ACTH, whether it is coming from the pituitary, the central, or the outside, we do a high dose dexamethasone suppression test to establish the central etiology. So normally in Cushing syndrome, if of central etiology, if we give the dexamethasone in a bit higher dose, because normally in low dose we are giving 0.5 mg, in normal overnight dexamethasone suppression test we are giving 1 mg, in high dose we give 2 mg every 6 hourly for 2 days. So whenever we give a slightly higher dose of dexamethasone over a period of 2 days, we see that the excess cortisol gets suppressed, and in our case there was more than 50%, even up to 92% suppressibility. Here we are having, before giving this high dose dexamethasone, we are having 18, and after that we are seeing suppression. So we did ACTH once more, and it was elevated further confirming our diagnosis of ACTH dependent Cushing syndrome. So basically, going by the history, initially it seems that the patient is having intake of exogenous medicine, exogenous intake of steroids. So likely it is exogenous Cushing syndrome, which is much more common. But it was not so in the case. Neither the patient was having a frank clinical picture of the characteristic clinical feature of Cushing, like proximal myopathy, like the characteristic stigmata, like wide purple stria. But still, as we proceeded step by step with the investigation, the screening part, the confirmatory part, we finally landed up in ACTH dependent Cushing syndrome. So patient had history of renal stone. We did a USG KB. It was not present. Because there was excess cortisol, it has a deleterious effects on bones. We also did a DEXA scan, which was suggestive of osteopenia at one or two sites. So as the central etiology was established, the source of cortisol was brain. So we did a contrast enhanced MRI brain where multiple adenomas were found out. So basically, the diagnosis of this uncontrolled diabetes was Cushing disease with diabetes, and it was only during this pre-anesthetic checkup that it was picked up. And finally, from a case of uncontrolled diabetes, we reached till diagnosis of Cushing disease, the Cushing syndrome of central etiology. So it is where sometimes we have to think open out of the box. And with this case in backdrop in mind, I would like to proceed a bit review the things that why did we suspect Cushing syndrome in this case, or what should be our criteria whenever a patient comes to us in our OPD. The patient is not being controlled despite adequate diet, lifestyle, drugs, insulin, or whatsoever. So when we should start suspecting, or what at minimum we can do so that we do justice to the patient and find out the etiology. So in this case, as I see, first of all, the main thing was history of exogenous steroid use, the Ayurvedic medicine history. Of course, the final diagnosis was not iatrogenic Cushing, but it was one of the first things which led us to think that maybe this uncontrolled diabetes is because of the iatrogenic steroids. Then in our case, the mooning of face was present. There was increased dorsocervical fat was there. Patient characteristically told that she has history of rapid gain in the last 1 year. So it was also one of the things which was not fitting in the picture. Of course, people have uncontrolled diabetes, may have weight loss or maybe weight gain, but rapid weight gain within a year. And yes, the most important part, difficult to control diabetes despite good compliance. So I think these are some of the things which should make us hint that maybe other things are also there. That's why I just would like to share that some of the endocrine diseases maybe the cause of uncontrolled diabetes or secondary diabetes. I know most of the things are rare only, but if we just uh, uh, pay some time to the patient, looking in the virtual cues or the markers, the stigmata of endocrine diseases, maybe that we may be able to we see that Cushing syndrome is a very rare. But still, if we even like acromegaly, the growth hormone excess, the pheochromocytoma, the primary halo, although the the problem with all these diseases is they are rare diseases, and it's not that they will be seen in every OPD. But if the endocrine stigmata we see in our case, then we should definitely at least do some screening tests. So like if we find out that in a case of Cushing syndrome, glucose intolerance can be seen up to in 30 to 70% of cases, while over diabetes is seen in only 15 to 20% cases. Same with acromegaly, around 50%. Dysglycemia is there, or both over diabetes or pre-diabetes seen in lesser cases. So basically, with this backdrop in mind, just like to go through some slides regarding why there is diabetes why there is exacerbation of diabetes or secondary diabetes in such condition. So whenever there is hypercortisolemia, there is some disturbance in the carbohydrate metabolism, and now this disturbance is at the level of the muscle. There is decreased uptake of glucose in the muscle. There is exaggerated lipolysis in the visceral fat. At the level of liver, there is increased gluconeogenesis and increased glycogenolysis. So all these things, they worsen the insulin resistance, and so making the diabetes control worse, if the person is already a diabetic or obese or having family of diabetes, all these condition, hypercortisolemic stress will worsen the disease further. So the patient will come with a plethora of symptoms and signs. The most common thing being the acne and the hirsutism. So the most common thing being the central obesity, the fat being accumulated in the central part. There can be the facial flushing or the plethora, the moon-like face, the acne part, or the purple-white stripe. So I'm going to show this is one of the case which had come to us. And through this case, I would like to just highlight on some of the endocrine stigmata which we can see in some of the cases which can be of secondary diabetes. Like in this case, if we see that there is slight mooning of the face is there. Sometimes when we say practically, how do we say that mooning will be there? We see from the front side of the patient, or we cannot see the pinna very clearly if we stand in front of the patient and try to see the pulna. So there is definitely mooning of face seen in this patient. Again, in the neck area, we can see a slight of darkening of the skin, the acanthosis. We can see the supraclavicular fullness in this patient. We can see the fat distribution predominantly in the centripetal area. So along with thinning of the limbs, sometimes it is known as the lemon on stick appearance. So in this we can see. And then again, we have some stria which are wide and they are reddish of purple hue. So sometimes it's not about inspecting the patient only for insulin injection sites. Many a times we can come across stria. Many a times we can come across the centripetal mooning and all. So in those cases, we can suspect Cushing syndrome. So now, suppose we have suspected, how to proceed further. It is very simple that we can go for we have to give this 1 mg dexamethasone at 1 p.m. Normally, the tablets are available either in 0.5 mg strength or 4 mg strength. So we have to give either 2 tablets of 0.5 mg, and like that, we have to measure the 8 a.m. serum cortisol next day. And normally the serum cortisol should be less than 1.8 microgram per deciliter. Yes, there are false positive and false negative that we have to keep in mind. But if the serum cortisol value is coming more than 1.8 microgram per deciliter, the ONDC is not suppressed, and there we have to proceed further with other things. And maybe that we need a team to find out the etiology of the case and other things. So I just want to highlight why Cushing's is diagnosis needs a detailed workup. It's not like a cross-sectional kind of thing that we do these things and we get the diagnosis. So in the workup for Cushing syndrome, first of all, not a single test diagnoses Cushing syndrome. We are doing first 8 a.m. cortisol, then we are doing the midnight cortisol. So the timing of samples is important. The sequence of tests is important. But I think whenever we are suspecting it, the bare minimum is that we can suspect in this etiology, and we have to exclude iatrogenic or exogenous Cushing in first place. So and many a times there are cases of other variety of Cushing which are cyclic Cushings, which have some normal tests and abnormal tests in between. That's why Cushing's is a very detailed workup, maybe. But the process should be that we should at least do a screening test. We can easily do a overnight dexamethasone suppress, and thereby we can proceed further. So this is just an algorithm. Wherever we suspect, we should exclude exogenous Cushing. Then we do a screening test, 2 out of 3, just like we did in this case. Suppose then sequentially we proceed for the ACTH levels, and then it is a detailed work. I'm not going further into the detail. My point of highlighting all these slides is just that the Cushing needs a detailed workup, and many times we have to wait. The patients has to be there to reach the. Similarly, in cases of acromegaly, where there is excess of growth hormone, again it is acting on at the level of liver, fat, even it is acting on the level of pancreas. So there is multifaceted actions of growth hormone which are responsible for excess insulin resistance and dysglycemia. Again, I'm wanting to highlight through this practical pictures what are the red flags that we see we can find in a case of acromegaly. So, like in this case, if we want to see that there is quite coarsening of faces, there is protuberance of maxilla, then there is like if we see the nose is very broad and bulbous, there is prominence of supraorbital like eyebrows, there is fleshy lips. So all in all, there is disfigured face. So if a patient is coming to us with like this, like prominent jaw and this disfigurement of face, the broad feet, and like all this, we can just have a increased suspicion of the other causes of diabetes. Similarly, if cases of uncontrolled hypertension with headache, palpitations, sweating, even they can present with worsening of diabetes or like that. So, I'm like if there is catecholamine access through the beta receptors, they are acting this. Through the alpha receptors, they are decreasing insulin secretion. So similarly, we have some patient characteristics in pheochromocytoma where we can do a simple screening test like plasma normetanephrine. If positive, we can have a detailed workup. So these, my point of highlighting all my case and all these endocrine cases, which are very rare, but still they are cases of uncontrolled diabetes, is that we not only have to treat diabetes, we have to give the definitive treatment of the disease. Like for acromegaly, diabetes control is a part, but definitely the definitive treatment is surgical resection of the GH secreting adenoma. Same with the Cushing syndrome, same with the laparoscopic adenotomy for pheochromocytoma and other things. So basically, diabetes control is a part, but that can be as a window to give the patient a definitive treatment, because all these diseases, the main problem is with the comorbidities, with the multiple organ damage, multiple cardiovascular risk and other types of. So until unless we treat the patient with a definitive treatment, which is usually most of the cases is a surgical thing, we are not going to do justice to the patient. So with this, I come to the last slide of my talk, and the take-home message is that not every uncontrolled diabetes is type 2 diabetes. We should look for endocrine stigmata, and iatrogenic Cushing syndrome should be suspected based on the drug history and the discriminatory clinical features that we should see. Uncontrolled diabetes, despite high insulin and OAD requirement and good compliance, should be thoroughly investigated, because there has to be something which is not doing just about sugar control. It is something else. And like there can be screening tests which can be either do by us, or they can be done before referring to an endocrinologist. So definitive treatment definitely solves the comorbidities, the accelerated damage and other preventive aspects that we can provide to the patient, and when we can do justice to the patient by removing him from all the comorbidities of the endocrine disease that he is being not relieved of. So with this, I would like to thank, and I would like to especially thank the RSSDI Rajasthan chapter for giving me an opportunity to share my thoughts on this case.
Thank you, Dr. Abhishek, for nice presentation and giving a good insight that every uncontrolled diabetes can have some other pathology also, and we should keep our eyes open. As in your case, some other problem may be there which can be the cause for this uncontrolled diabetes, and which may have ultimate effect on the prognosis of the patient or ultimate outcome of the patient. So we have to keep our eyes open. And before I talked to you last week, I also had a case of, as yesterday I was telling you, a patient of the CRPF came to me around 10 days back that he wants fitness, as annual examination was done 2 days back and he was diagnosed diabetes. And on examination, I found that he was acromegaly. I told him that I will not give you the fitness. I can tell you this tablet. I had asked him to go for these investigations. He refused. It will create a problem for my job, and I may get retired from the job also. So I told him that you take this medicine, get cleared, and at least you should get worked up so that your problem basic problem can be identified. So acromegalics are also comes quite frequently for the diabetes. It was a nice case.
Thank
And
you,
we
sir.
have to keep not only these endocrinopathies, many of the patients are taking certain drugs which can also cause uncontrolled diabetes or some other things which can cause all these. Dr. Deepak, will you like to say something?
Yes, sir. I think Dr. Abhishek is already very beautifully explained the case. So definitely we should think about the secondary cause of the diabetes in the patient on proper medications. Compliance is good. Already taking the insulin high dose, sometimes patient weight is around 80 and taking the 100 to 120 units and other which after that the blood sugar is not controlled. Definitely we should think and definitely sometimes we will find this real cause of the diabetes. If we found the cause, definitely and diabetes is
Your voice is not coming clearly, Dr. Deepak. Your voice is not good.
Hello?
Yes. Yes, now we can hear.
Yeah. Yes, sir. I think it's beautifully explained by the Dr. Abhishek. So
Yes, yes.
everything is covered. So we should think.
Dr. Sanjay, your comments. Dr. Sanjay Saran.
Yes, sir. Sir, actually, this is really a very beautiful case, and it was beautifully presented by Dr. Abhishek. Really, such kind of the problems we can see in our day-to-day these references. Usually, whenever we see the reference for some surgical patients like that, uncontrolled blood sugar, usually Cushing syndrome. Whenever we are getting some reference of uncontrolled blood glucose level in spite of the optimal amount of insulin or oral hypoglycemic agent, then obviously we should suspect regarding Cushing syndrome. Obviously, other acromegaly and some other syndromes we can easily recognize by the features, clinical feature of the patient, but the Cushing is very notorious. It's very difficult to diagnose the Cushing syndrome because many of the conditions like pseudo-Cushings are also there. Patients who are undergoing the surgery or for that. And the other thing is that he has just beautifully seen, diagnosed the patient as already patients was getting some exogenous steroid in the form of Ayurvedic medicines. So really they have diagnosed some good case or they have just beautifully managed the patients. So congratulations to Abhishek for the good presentation and also for the good suspicion on the patient. And also
Dr. Anil Samaria.
Yes, sir.
Yes, your comments and what
Very nice presentation, Dr. Abhishek.
How we should be watchful for finding out these patients with their other problems in addition to the diabetes. Can you give some tips?
Most of the patients we have diagnosed as diabetes with a rare presentation. We see in the day-to-day practice lots of Cushing-like pictures, as said by the Dr. Saran. We see the acromegaly cases, hypothyroidism, acromegaly, various other causes of primary aldosteronism, glucogonoma. These are the rare cases that can present like a with a presentation with diabetes. So we have watchful on all these rare causes. Whenever you see this kind of patient, especially his facial features are very important in these situations. Cushing patients are most likely to see in the day-to-day practice because lots of patients consuming oral Ayurvedic medicine that contain the dextrona especially and steroids. Even we see the patient came with a complaint of कि सर मैं प्रैक्टिन डेक्सोना खा रहा हूँ वजन बढ़ाने के लिए काफी टाइम से अब मेरा ये हो गया हाल आप बताएं क्या करना है. We see the all the classical feature of Cushing syndrome, fat, stria, the moon-like faces, and the patient presented with the diabetes in the most of the in day-to-day practice. So we keep watch all these feature whenever see the patient with diabetes in first time presentation. So take a good history with a good clinical examination is a very important part. congratulate Dr. Abhishek. Very nice
Thank you, sir.
presentation of case.
Thank you, Dr. Anil,
Thank you, thank
for
you.
your comments. Dr. Shailesh is also online, and Dr. GD, your comments. Dr.
sir.
Palani want to say a few words, something.
Congratulations, Dr. Abhishek, for nice
Thank you, sir.
presentation. And one query regarding how she gained so much weight in a year. And second part of my question is treatment parts, like comments on the treatment of such cases. Thank you.
Sir,
Dr. Prakash, can I intervene?
Yes, sir. Just wait.
Yes, sir.
Let him answer Dr. Gwalani's questions. Then, if we can go for one by one, it will be better.
Sir,
100%.
so
Sir.
sir is management of such kind of cases.
Yes, sir. So, normally, first of all, your first question, it was how she gained so much weight. So, as I told that she was having weight gain for the last 1 year, it is because of the cortisol excess. She was having all the features, and there was decreased physical activity and all other part also. So, because of hypercortisolemia only, the increased weight gain was there in this case. And as I told that, apart from that, she got lazy. Her lifestyle also was sedentary and other things. So definitely that also contributed to rapid weight gain. So in Cushing cases, we usually see. And as regards treatment part, since in this case, the reason for Cushing syndrome was a microadenoma. So normally we go for the definitive treatment, which is the surgical resection of the tumor, which we usually, since these are microadenomas less than 1 centimeter, so usually transnasal, transsphenoidal route we go and we remove the adenoma. But in our case, I would like to express this that since the case was a bit lost to follow up and it was COVID time, so I think we lost the case before proceeding further with the definitive diagnosis. And interestingly, this case was having multiple adenomas. So when a Cushing syndrome case is having multiple adenomas, we usually have to localize the site of the excess cortisol secretion. So for that, we have to do further investigations like inferior petrosal sinus sampling, which we could not do in this case. And ultimately, the case died. But yes, definitive treatment, we can start medical treatment also, like with drugs like ketoconazole and other newer drugs. But definitive treatment is surgical resection only, sir.
Thank you.
Dr. Shailesh, Dr. GD.
Yes, sir. Good evening, everyone.
Good evening, sir.
This was a typical case of Cushing syndrome, very clear-cut. So generally in practice, we don't see such clear-cut cases. We see many subclinical Cushings, and it is the high index of suspicion which we have to keep when, despite of all the efforts, when sugars are not getting controlled and patient is constantly gaining weight, then we have to suspect Cushing's, even in the absence of those florid symptoms which Dr. Abhishek highlighted. So plain Cushing is easy to diagnose, but subclinical Cushing's we have to suspect. And as he highlighted, the simplest, very simple test, overnight dexamethasone suppression test. Just give 1 milligram dexa at bedtime, 11 p.m. and next morning 8 a.m. cortisol. So very important message for all clinicians that suspect Cushing's in such situations and diagnose and then refer. And one more point which Dr. Abhishek again highlighted, that even after localization of visualization of adenoma on MRI, it is not certain that this patient would get rid of the disease if you remove this adenoma, because Cushing is very notorious, and sometimes you may be just removing the incidentaloma, which may not be responsible for over secretion of ACTH. So it is very important to correctly diagnose and localize left or right before proceeding for surgery. And even at best of the centers, sometimes people fail to localize correctly.
Thank you, Shailesh, for your nice inputs. Dr. Pradyuman Sharma, you wanted to ask, give your comments.
No,
Pradyuman boss.
let me congratulate. It was a beautiful and exhaustive presentation and exhaustive workup.
Thank you,
by
sir.
Dr. Abhishek. My all sincere congratulations. One thing I don't understand, with an 80 centimeter waistline, with a 34 practical, you can never have an 80 centimeter waistline with a 34 BMI, number one. Number two, when you find the problems, why the lady was allowed to patient who is not responding, who has a uncontrolled diabetes, should never be allowed any medicine which is not has a, you cannot substitute what you are giving or not. So these are 2 point lines. But anyway, my all congratulations. It was a beautiful and exhaustive workup. Thank you.
Thanks, sir.
Thank you. Thank you.
In fact, sir, I would like to thank to my fellow colleagues at my Safdarjung Hospital, New Delhi, my colleagues and my teachers who guided us well. And it was, in fact, a teamwork at Department of Endocrine, Safdarjung Hospital, for which because we had to keep patients in mind, because the investigation took like 10 or 15 days. The patient was not cooperative. So it was a teamwork from Department of Endocrine, Safdarjung, which lead to the diagnosis, and especially from my colleague over there, Dr. Rahul. So it was a teamwork, sir.
Dr. Surinder from Bikaner. I think he's online.
He's not.
He was up to few minutes back. He was there. Dr. GD.
Yes, sir. Thank you, Dr. Keswani. First of all, I would like to congratulate Dr. Keswani for getting the wonderful presentations and cases for general physicians, which we are day to day we are missing. Practically, we are missing. Of course, it's not very rare. We are also getting such type of patients with uncontrolled diabetes with full dose of quite a high dose of insulin plus OHAs, and still not controlled, and patient is getting weight. So still, I think it's a high index of suspicion. As Dr. Shailesh told, that first of all, you should think it may be some other cause also, as Abhishek and Dr. Shailesh told. So probably we still not going for this ONDST and IGF. I think probably we should do these tests in routinely in suspected cases before, because we are increasing the dosage, and again we are same history patient repeats. Control but getting weight, and we are increasing the doses, but still not controlled. So it's very good message given by Dr. Abhishek and Dr. Shailesh for such patients. We should do routinely in suspected cases that overnight dexamethasone test, and maybe in some cases IGF also. So thank you very much for a wonderful presentation, Dr. Abhishek. Excellent.
Thank you, sir.
Thank you, Dr. GD, for your nice comments. We have very good comments from a number of audience. Dr. Geeta Arora, Dr. Ramya Ravichandran, and so many other doctors have also given Dr. Daria has given their comments that it was a nice and excellent presentation. So congratulations, Dr. Abhishek.
Thank you, sir.
You've done a very good job. A nice lecture, nice learning for all of us.
I think Dr. Surendra is also not here. We would like to congratulate him also. I think he's getting the award in Diabetes India.
Okay, that's good.
वो शायद online नहीं है अभी. So
up to few minutes back he was there.
I think Dr. Hemant sir is also asking something.
Dr. Abhishek, I
Yes,
want to have your comments on Cushingoid and Cushing. So many physicians are there, so it will be revision, Cushingoid and Cushing.
So normally Cushingoid features can have a variety of features. If you see from head to toe, like if you see a patient coming to us from head to toe, there will be mooning of face, there will be facial redness, which is facial plethora. Then we move a bit down. Then there is supraclavicular fullness if you see anteriorly, then buffalo hump posteriorly. And there we come down, then we have this predominantly centripetal obesity with stria. It is basically the stria, and there can be skin thinning, there can be spontaneous bruises, there can be proximal myopathy. So what is there can be many features which are Cushingoid, which look like Cushing, but 3 or 4 features which are very discriminatory or very specific for Cushing disease, they are the discriminatory or characteristic features which tell us that it is Cushing syndrome. So they are one, proximal myopathy. The patient will have difficulty in climbing the stairs or something, or then these are the stria, which are typically more than 1 centimeter. They are wide, the purple dehiscent. Then we have the thinning of skin, then spontaneous bruises, and the facial plethora. So these are 3 or 4 features, especially the proximal myopathy, the peculiar stria, which are very characteristic for Cushing disease or Cushing syndrome, rather than Cushingoid appearance per se. So we have to look, that's why I use the word Cushingoid faces, Cushingoid appearance, but no discriminated features. As soon as we are finding these discriminated features, we are more inclined towards the diagnosis of Cushing syndrome.
That's great.
Thanks a lot.
Thank you, Dr. Abhishek.
Thank you,
Dr.
sir.
Pareek, sir, we would like to conclude this session.
At the outset, let me compliment and congratulate Dr. Abhishek for a excellent presentation.
Thank you, sir.
And very well presentation of the case. Here comes the importance of clinical examination of a patient, which we are forgetting in our busy practice. Even when you know that a patient is a diabetic, he has got high blood sugar, we need to examine a patient completely, at least first time when he comes for a consultation, so that we can know so many things. As Dr. Abhishek, while examining, he could find out that there is a possibility of Cushing syndrome, and then he was investigated. So it is very, very important, even in our busy schedule and busy time of practice, when we do not get a time for examination of a patient and we depend more on investigation, this is the right approach to examine a patient, whether he is from diabetes or hypertension or something else. So it's really a great lesson from Dr. Abhishek that every patient, whatever may be the disease, once complete examination is very important. Maybe with his colleagues or junior assistant or registrar or house surgeon. So it is, one has to be evaluated, a patient has to be evaluated completely. So thank you again, and thank you, Dr. Prakash Keswani, for updating educating all of us with newer and newer things in diabetes. And I think these case-based discussions are very, very important as compared to lectures, because here we get a time to discuss each and everything, and about our queries we can fulfill them. Thank you very much, Dr. Prakash Keswani.
Thank you, sir. Thank you for your nice comments. Thank you, everybody. Thank you, Abhishek, Dr. Sanjay, Dr. Shetty, Dr. Deepak, Dr. Anil, Dr. GD, everybody. We will meet again on the 8th of February. The next month again on the second Thursday we will be meeting on the I think it is on the 8th of February.
Next week on Thursday we are having a IACM online meeting on some different subject. So next Thursday, I mean next Thursday of the next week of this month,
we will join
online CME at 8 o'clock, 8 p.m.
Yes,
you all are invited to.
Sure, sir. Sure, we will join.
Sure.
That's CME program. Thank you.
Thank you, sir.
Thank you, sir.
Bye-bye.
Thank you, sir.
Good night. Good night, sir.
Good night, sir.
Bye-bye.
Good night, sir. Good night.
Bye-bye. Thank you.
Good night. Good night.